Hello, tech team. Good evening. Hello. Hello.
Hello, sir. When can we expect the doctor to join?
Sir, good evening. Hello. Hello. Hello.
So, sir, when can we expect the doctor to join?
Hello, tech team. Good evening. Sir, I am audible.
Yeah, sir. When can we expect the doctor to join, sir?
हेलो हेलो टैग टीम।
Hello, sir. When can we expect the doctor to join?
सर आई एम ऑडिबल।
Yes, sir. Audible clearly, sir.
सर विल स्टार्ट विद इन 10 मिनट्स। डॉक्टर इज विद द पेशेंट।
O-
विद इन 10 मिनट्स विल स्टार्ट सर।
Okay, sir. Okay.
हेलो। हेलो।
Hello, हाँ sir.
अ, सब लोग हैं?
Yes, sir. ये attendees अलग लिंक पे ज्वाइन हुआ है.
जावेद सर गुड इवनिंग।
गुड इवनिंग।
हाउ आर यू सर?
या फाइन।
तो सर विल स्टार्ट। यू शेयर योर विद योर एंड सर और आई विल शेयर द स्लाइड्स।
शेयर द स्लाइड।
यू कैन शेयर द। सर आप अपने एंड से शेयर कर देंगे या मैं शेयर करूं सर?
एक सेकंड में करता हूँ।
ओके।
शेयरिंग का स्टार्ट शेयरिंग, ठीक है। ये ओके दिख रहा है?
नहीं सर अभी नहीं दिख रहा है।
एक सेकंड। ये पीपीटी है या पीडीएफ है?
ये सर पीडीएफ है।
अच्छा अच्छा, ठीक ठीक।
मैं शेयर कर देता हूँ सर अगर इशू है तो।
हाँ, शेयर कर दो आप थोड़ा सा।
हाँ ठीक है सर। इट्स विजिबल सर।
या ठीक है।
ओके। तो सर पहले मैं इंट्रोडक्शन करवा देता हूँ, फिर उसके बाद आई शेयर द स्लाइड एंड यू कैन प्रेजेंट सर। हेलो गुड इवनिंग एवरीवन। I am Mohammed Amir from Diabetes Care Division of Glenmark. On the behalf of entire team, I extend a warm welcome to each of you for today's ECME session on telegliptin. For today's session, we have Dr. Mohammed Javed sir with us. Over to you, Javed sir.
Good evening, everyone. So today I will discuss about the tinagliptin and its combination for the blood sugar control, that is glycemic variability, and also in terms of cardiorenal safety, and in terms of the fatty liver disease. So it will be combinations for cardioprotective and also for renal protection also. So tinagliptin are, as we can see from this one, it is for the cardiac safety and also for the renal safety and in combination with SGLT2. So when it is in combination with SGLT2, it cause amplify the effectiveness of the tinagliptin, and in also uh, when we are giving the dose for the tinagliptin for the cardiac safety is 20 milligram or 40 milligram. It does not cause QT and QTC interval prolongation, but few of the drugs that cause QT and QTC prolongation also. But in terms of the renal improvement, glycemic control, preserve renal impairment, and also helps in the renal function also, and significantly improves overall main role that we use for the blood sugar control. So significantly it improves glycemic control. And once we will be having good glycemic control, so HbA1c across all age group, it will be controlled. Next. So if we look of the top tier study, teneligliptin on glycemic control parameters, time in range. So this is one of the important prospective multicentric open label study conducted on effect of teneligliptin on glycemic control through parameters conducted by Dr. Sabu and Suhas and Dr. Unni Krishnan. This is one of the good research paper I had also went through multiple number of times. Next. So summary and conclusion of top tier studies, teneligliptin treatment reduce the glycemic variability when any patients is sometimes come with very high variability, like having sometimes the blood sugar of very high and then suddenly the hypoglycemia also. So it, in terms of it reduce the glycemic variability, plus it improves the mean hemoglobin A1C at the end of the study, and this study also comes that it leads early glycemic improvement, that is within 10 days. Can promise drug reduced glycemic variability in patient with type 2 diabetes. Mainly it is the work it function in terms of we can say that it also helps in terms of what we say is resistance development also. So next is the effect of teneligliptin versus sulfonylureas on major adverse cardiovascular outcome in patient with type 2 diabetes. So cardiovascular outcome in real world setting, that is the Korean National NHS service database. This study was conducted at Korea. Next. So these teneligliptin and sulfonylureas on the major adverse cardiovascular outcomes, and if we look the severe hypoglycemia, which evident is 1.65 per 100 patients per year, compared to sulfonylureas, which cost 2.39 per 100 patient. So the severe hypoglycemia associated with teneligliptin is lesser compared to sulfonylureas. So the evidence for teneligliptin's cardiovascular safety is did not cause QT interval that we have earlier discussed. Second thing is that we can titrate the dose from 20 to 40 milligrams, but did not cause QT and QTC prolongation. And it also, the study also conducted on the Indian populations also. Next. So evidence of teneligliptin and CKD, if we look after the evidence of teneligliptin and CKD, we have seen that the real world prospective multicentric study, 24-week study duration it was, and 377 patient was enrolled, and with the criteria of EGFR is less than more than 15 and less than 60. The outcome is that to effect of teneligliptin or renal parameters in type 2 diabetes is CKD. So in this, the conclusion was that there was significant improvement in the renal profile and glycemic control in Indian population with uncontrolled diabetes mellitus in real world setting, demonstrate it is the safe and effective. Then there is tinagliptin plus dapagliflozin and versus sitagliptin with dapagliflozin and linagliptin with empagliflozin. There are two comparator with test arm with the tinagliptin with dapagliflozin. Efficiency of DPP4 plus SGL2 in improvement of parameter of 24 of glucose monitoring. So while amplifying, then the glycemic and renal parameter improves when there is a teneligliptin with DAPA combination where compared to other study arms. And FDC of teneligliptin with DAPA was comparable to SITA and DAPA, EMPA and LINA in improvement of renal parameter and glycemic variability parameters also. Tinagliptin along with pioglitazone and metformin. These were phase 3 study was conducted, randomized double-blind comparative study, multicentric. It was 24 weeks duration. It was, and in this metformin, pioglitazone, and tinagliptin was given in combination. So two groups were formed. One is test, one is comparators. Tinagliptin 20 milligram was used and 30 milligram pioglitazone in one group, and in the test group, tinagliptin 20 milligram with pioglitazone 15 and another group with pioglitazone of 30 milligram. So inclusion criteria, those with hemoglobin more than 7 and excluded those patients having hemoglobin A1C more than 10. And during the study, more than less than 1000 milligram of metformin was given regularly. So more than 1000. So in the conclusion of this study, the combination of TINA, PIO and METO, this improved the efficacy as compared to monotherapy of TINA or pioglitazone alone. Then the combination of TINA, PIOs and metformin has no increased risk of hypoglycemia, and there was no side effect with each others. And it was well tolerated also. So in summary, number one was that teneligliptin was not associated with increased cardiovascular event. And number two, there is lesser risk of hypoglycemia. Number three, the renal profile and glycemic control in Indian population with uncontrolled diabetes mellitus combination therapy has significant improvement. Then on amplifications, that is a combination of teneligliptin with dapagliflozin, there is a good if we use the continuous glucose monitoring, the parameters was very well maintained. And in the fifth summary, fifth point was this is highly beneficial in liver steatosis and inflammation and reduce the advancement of fibrosis. Thank you.
It's finished, sir.
Yeah.
So, sir, closing remark after all the Dr. Javed sir has talking. It has been an insightful and enriching session on the role of teneligliptin with the combination metformin like pioglitazone. And sir, a special thank for our extreme speaker, Dr. Javed sir. Thank you, sir, for sharing your expertise on this topic. This session has provided us a valuable takeaway. I also want to thank all the participants for their engaging contribution. Thank you, sir.
Thank you. Thank you.
Team, it's finished. Now you and me can both leave. Hello, team. Hello.